Thanks, Leah. Good afternoon, and thanks for being here today. I'm Jennifer Hansen, Pain BC's Director of Education and Engagement, and I'd just like to give you some context and background for today's talk as it addresses a particularly sensitive issue within the pain community, medical assistance in dying, or MAiD. Although legal in Canada, MAiD is a subject of considerable public debate, reflecting the diverse perspectives of Canadians, including those living with chronic pain and the providers who care for them. Although the legal discussion has been about assisted suicide and voluntary euthanasia for those with terminal conditions, many of you have been asking about what it means for those living with non-terminal chronic pain conditions. Pain BC welcomes the public discourse around this topic as it brings to national attention the suffering that people with chronic pain endure every day. Without an adequate system of care or reliable access to effective pain relief, in some cases, a patient's suffering can become so overwhelming that it raises questions about not wanting to live at all. Pain BC is mindful that within this context, people living with chronic pain are vulnerable due to a higher risk of depression, anxiety, comorbid illnesses, and prolonged poor symptom management. They may be asking more frequently about medically assisted dying, and in some cases, seeing it as their only option. I want to emphasize that Pain BC believes providers need to take extra care and use extremely sound judgment when advising this particularly vulnerable population about medically assisted dying. Pain BC believes that pain does not have to be a barrier to living a full life. All our efforts are directed to empowering people in pain to live as best they can while acknowledging the real challenge of pain that persists. We know that many people living in pain find that connection, support, and education can make a positive difference in their lives, and we aim to support everyone in need, especially those individuals in their darkest hours. So within this context, we hope today's webinar will give you as a healthcare provider a better understanding of how Canadian laws for medically assisted death apply to patients with chronic pain, the skills to explore other means of easing suffering, and with that, the knowledge and confidence to address your chronic pain patients' questions about MAiD. I would ask everyone to note that while there will be an opportunity for questions at the end of the presentation, this session will not provide an opportunity to debate the ethical or moral implications of MAiD. Our purpose today is to share information and offer practical communication strategies. So on that note, I'd now like to introduce today's presenter, Dr. Stephanie Green. Dr. Green spent 10 years in general practice and another 12 years working exclusively in maternity and newborn care. Recently, she pivoted and started working in medical assistance in dying. After some MAiD education in the Netherlands, she was one of a handful of physicians who started providing MAiD care in Canada in June 2016. She is the president and co-founder of the Canadian Association of MAiD Assessors and Providers, CAMAP, and webmaster of CAMAP's National Listserv for MAiD Providers. Clinically, she is focused on providing medical assistance in dying in and around Vancouver Island and making Canada a leader in this new field of medicine. She enjoys educating both the public and her peers about medical assistance in dying and hosted the MAiD 2017, a national conference on MAiD in June. Dr. Green is clinical faculty at UBC and UVic. Over to you, Dr. Green.
Thank you, Jen. I appreciate that introduction. Hello, everybody. I hope you can hear me all right. Thank you for joining today. A big thank you to Pain BC for organizing this webinar and for asking me to participate. I appreciate the opportunity to reach out to other care providers and members of your community. I'm assuming that I have the screen is appropriate right now. So
yes, just give me 2 seconds here, Dr. Green. Sorry about that. I'll be giving you screen sharing ability right about now. Here we go.
I thought so. Great.
There you go.
I will show my screen. How's that working?
We can see your screen, yeah, and you can just go to PowerPoint there.
I'm not seeing that. Fascinating.
Okay.
My screen just disappeared.
Okay. Sorry about that, folks. Just give us
All right,
2 seconds. There we go. We got it. Okay, great.
Okay, great. Okay, thanks, guys. Sorry about that. So I'm just going to briefly go over what I'm going to go over. I'm going to try to cover a lot of information today, and I'm going to try very hard not to speak fast. That's something I do. But basically, we're going to go through some terminology so we're on the same page. I'm going to give a very brief history of how we got to where we are today. I think the context is very important in this topic, and especially in the chronic pain community. We're going to outline the process itself, or how to access medical assistance in dying in Canada, what the current law states, what the eligibility requirements are, and go over some cases that I think might be relevant. And then we'll flip over, and Leah will give us some extra information about the chronic pain community and some resources that are there. And if there's more time, that we'll obviously, I'm happy to answer any questions about my own personal experience. We'll definitely make sure there's a good amount of time for questions as well. I think that's important. So again, context is always important. Just about me. Thank you for that introduction. I think you know everything you need to know. I have no conflicts to declare. I am trained as a family physician, and I did work in general practice and spent most of my career in maternity. So this is a big change. I do still work in some newborn care, and I'm working almost full-time in medical assistance in dying, which from this moment on I will just refer to as MAiD because it's easier to say. I have been working since the very first day that this was legal in Canada, since June of 2016. And I should just note that I work with a number of colleagues in a number of fields. This has been an extraordinary experience for me. I work on the ground with the IV nurses, with health authority members, members of the college, professionals from nursing, occupational therapy, social work, spiritual counselors, a whole variety of other care providers. It's really been an extraordinary opportunity for me. And we've already mentioned my association with CAMAP. So just so we're on the same page, depending what you read and who you read and what year it was written, there is a number of different terminologies being used. So just to be very clear, assisted suicide is the prescribing of a lethal medication to be taken by the patient. So I can assist someone in their death by prescribing the prescription, picking up the prescription from the pharmacy, going to the patient and giving the medication to the patient, who then administers it for themselves. That is what's known as assisted suicide. Voluntary euthanasia, on the other hand, is the administration of a lethal medication by a healthcare professional at the explicit request of a competent patient. So that's when I pick up the medication from the pharmacy, go to the patient, and actually put in the IV in their arm and actively deliver the medication that will cause their death. So there's a subtle but a very important difference between those two. So making sure that that's clear. Now, in Canada, we actually have both of these things allowed and legalized and regulated at a federal level. So medical assistance in dying is actually a uniquely Canadian term. This doesn't exist anywhere else in the world, and what it encompasses is both those aspects of assisted death, and also the fact that it could be either a physician or a nurse practitioner who's administering this care. That unique bundle of options is called medical assistance in dying. And by making this legal in Canada, we have joined a very exclusive club globally. In fact, there's really only 3 other jurisdictions in the world where both of these opportunities exist, and that's famously the Low Countries, so the Netherlands, Luxembourg, and Belgium. What we see on TV and hear about our friends in the United States and in Switzerland, they hit the media a lot, but they actually only have assisted suicide. Neither of those countries have in any form of voluntary euthanasia. And I should just mention that in Quebec and Canada, we also we don't have assisted suicide there. There's only voluntary euthanasia. So just to clarify what's happening. A word on language, I don't think I can emphasize this enough, but how shall I put it? When I first walk in to see a patient, to meet a new patient who's been referred to me for this care, I immediately break the medical school rule, which is that you're supposed to sit down, be quiet, and let the patient talk to you so you know what's happening and kind of ascertain their chief complaint, so to speak. But in this care, I actually do the opposite. I sit down and I immediately tell them 2 things about myself. And the very first thing I will tell a new patient is that I'm a very direct doctor, very blunt. I'm here to talk about their death and their dying. I'm going to call it that. I'm not going to use metaphors, and I'm going to speak very plainly. And I immediately almost 100% of the time, I'm immediately hit by the relief on the patient's face. It's extraordinary what happens when you invite the patient into that conversation with you in a very open and honest way. And then, of course, my job is to be quiet and to listen to what they have to say. And I would encourage anybody who's working in healthcare, but especially anybody who's approached about this topic or wants to discuss medical assistance in dying, to try to speak as plainly and as transparently as possible. You'll find that patients really appreciate it, that they feel validated, they feel invited to have the conversation, they feel free to be honest in their conversation with you, and you'll find that you'll get a lot more truth from the patient. So then the most important thing is to listen. And when we listen to patients talk about their death and their dying, we sometimes hear that they're in pain. We sometimes hear that they're suffering. There's a definite difference between the two. It's probably a community I don't need to clarify that in. And we can really help ascertain whether they're looking for help to die or actually something else. So I can't stress that enough. I think that's very important when you're in this field. The patients will feel much gratitude towards you if you speak in that way. I am going to put this in context. So medical assistance in dying in Canada came into effect in 2016, but this story goes back certainly much further, but certainly begins in 1972 when suicide became no longer a criminal offense in Canada. Since that time, the criminal code does not include suicide as a criminal offense, but assisted suicide had been on the books as a criminal offense. Jumping ahead to 1993, most of you will be aware of Sue Rodriguez, a young woman actually based in Victoria, where I am, who was in her 40s and was diagnosed with ALS, which is a chronic progressive neurologic condition, which is ultimately uniformly fatal. And she fought for the right to an assisted death because she felt that she wanted control at the end of her life about how she would die and when she would die. She didn't want her disease to determine that. And she wanted the ability to make that decision herself. She fought that through the court system all the way up to the Supreme Court of Canada, and most of you are aware that she lost that fight in a 5-4 decision by the Supreme Court of Canada against her right to assisted death. That sparked a lot of debate in this country, and I will skip ahead another 20-something years when in April 2011, a few plaintiffs, one of them again with ALS and another one with spinal stenosis, they challenged the exact same law that was taken to court by the British Columbia Civil Liberties Association, filed suit challenging the exact same law, and a 5-year saga basically also ended in the Supreme Court of Canada hearing that case, and famously, of course, unanimously struck down that law prohibiting assisted suicide. So that was a 9-0 ruling. So a very big change in the Canadian public's sentiment and that of the court over that short period of time. This case, which changed the law, is known as the Carter case. And I would just say that the trial judge, and all the way up to the Supreme Court, the wording that was used in this decision was very carefully crafted by a constitutional expert and laid out very clear criteria for who would qualify for this care. And everybody thought that the government would then take that decision and turn it into a law to regulate MAiD in Canada, but that's not what happened. And this becomes relevant, I think, to this discussion today. So it was June 17th, 2016 that what's famously known as Bill C-14 became law in Canada to regulate assisted suicide, which is now known as MAiD. And the Carter decision, the eligibility were very clearly laid out, and there were only 4. In order to be eligible for this care, you needed to be an adult, which was defined as 18 and over. The patient needed to be competent to make this decision, to understand what they were asking for. They needed to have what's known as a grievous and irremediable medical condition, and they needed to be enduring suffering that was considered intolerable to themselves. And those were the only criteria. But when the law came into effect, it had been changed by Parliament, and Bill C-14 was not the same as that. And we're going to get into the details of what that means and where that's changed in just a moment. Before I do that, though, I just want to, again, contextualize this by looking at some of the data from the Netherlands. Now, we know that in the Netherlands, this has been going on for about 25 years, and there's lots of very, very good data there. So it's not all necessarily relevant to what's going to be happening in Canada, but it is an excellent model, and I think it's worthy of looking at, because it's always feared, of course, that when there's new care implemented, that it may not be done well, or that there may be risks involved. And certainly around the issue of MAiD and euthanasia, we'd like to know whether we're doing it right, or whether there are real risks, and whether there are significant vulnerable populations that are at significant risk. So the question is there truly a slippery slope? And I would say let's look at some of the data there. The classic fears, of course, are that there might be an increased desire to perform medical assistance in dying once it becomes legal, that there might be an increase in terminating someone's life, maybe even without their request, which is always a fear, that vulnerable groups like the elderly or the disabled might be more at risk for this happening, that there might be more and more and increasing numbers of cases, or that there might be more pressure to grant requests as time goes on. So I'm just going to touch this very, very briefly. Has there been an increase in desire to perform euthanasia in the Netherlands since it became legal, and since they've been looking at data since the 1995? Well, actually, the data there will actually tell you that the willingness of physicians to perform this service has basically been entirely unchanged since the law has changed, and since this has become a normalized part of their society. Has there been an increase in euthanasia in people with less serious illnesses? So, for example, I can tell you that about 85 to 90% of all cases of euthanasia in the Netherlands are performed by family physicians, that 70% of all cases are done in patients with cancer, and that currently they're reporting about 4.6% of all the deaths in the Netherlands to be done by euthanasia. What about people with less serious illnesses? If we look at that data over the last 20, 30 years, we also see that the percentages of patients with other diseases has not really changed. So this has also stayed very, very consistent over time that they've been collecting data. Has there been an increase in euthanasia in the elderly or in other vulnerable groups? Again, the data shows a very, very steady rate of the age range of people who've been requesting and accessing this care. And it's not just the elderly, it's also here you can see people at risk, for example, people with dementia or psychiatric illness. It's a very, very, very small piece of the population. In fact, it's only begun since 2010, and it remains a very, very small piece of who's affected. So I just wanted to put that into context. What's actually happening in Canada, you can see here the blue lines represent the actual total number of MAiD deaths in Canada in the first year of this legalization. And what I've done is, because it's not very comparable because of populations, I've taken the liberty to convert these numbers to a percentage of total provincial deaths. So you can see it's fairly steady across the country. There is a bit of a spike in Quebec, where they have been ahead of us in this game, and you can see there's a bit of a spike in British Columbia, where not only do we have a lot of requests and access to care, but it's actually significantly more than across the country. And by converting it like this, we can actually compare to other jurisdictions. I mentioned that the Netherlands and Belgium both actually report that 4.6% of all their deaths are done by assisted dying. You'll see that in Canada in the first year, Canada's only 0.9% of our total deaths were done by medical assistance in dying. So it's a very, very small sliver. You can see that British Columbia is more than that, about 1.2%. Maybe a little bit more actually. And I just noticed, just point out to you that on the far right there on the slide where it says IH, that is actually representative of island health. So Vancouver Island and the Gulf Islands are its own health authority, and for some reason here our rates are very close to those in Netherlands and Belgium, and that's a topic of a different webinar I'd love to get into another day with you, but I find that quite interesting. So more practically, what is the process for accessing medical assistance in dying in Canada? The first thing I want to mention is that the patient themselves are always, always at the center of this care. This is a patient-driven care. This cannot be requested by anybody else or on their behalf. So there needs to be a minimum of 5 people involved in this process, with the patient being 1. There need to be 2 witnesses to the request, and there need to be at least 2 independent healthcare professionals. So what does this look like? To make a request for medical assistance in dying, you have to ask for it not just verbally, but also in writing. And the request has to be on a specific provincial form. It needs to be witnessed by 2 independent witnesses. And the requirements for who those are, just very briefly, they need to be adults, they need to understand what's being requested, but more importantly, who they cannot be. They cannot be people who will benefit in any way from the death of the patient, who are related to them, who are named in their will, who provide them medical care, or who provide them personal care. So those people are not allowed to witness this request. And there is a 10-day waiting period after the request is made before you can go on and proceed to this procedure. Where do you get the request form? Well, in theory, any physician or nurse practitioner should be able to provide a patient with that form, but in practice, it's not always that simple. There are a number of us that have websites online where patients can self-refer and find all the information they need about medical assistance in dying, but the real answer is the bolded answer at the bottom of the slide, which is that every single health authority, I'm speaking now about British Columbia, of course, has a MAiD care coordinator, and if you simply Google the name of your health authority and MAiD, you will find a phone number, a fax number, a website, and lots of patient information that's available. So patients can self-refer, physicians, clinicians from any field can find out all the information they need from their local health authorities. That's not grossly true across the country, but generally true everywhere. The assessment itself for patients, like I mentioned, has to be done by 2 independent medical providers. Independent means that they don't have a relationship together of maybe mentor and student, or someone who's hired one or the other. There's no conflict, basically, is what we're looking for. And of course, it's always possible to use extra consultants if required. Sometimes that requires a psychiatric consultation, a neurologic consultation, or other specialists to provide the appropriate background. And there's no limit on how many consults can be used, but there's a minimum of 2 independent assessments that need to be made. The law itself, I'm going to actually go through each one of these very briefly with you, so there's a much better understanding of what's involved and who is not eligible. And then I'm going to get onto some cases. So as I mentioned, you do need to be an adult to access medical assistance in dying in Canada. That needs to be the same across the country, and that has arbitrarily been taken to be 18 and over. So that's a clear and easy one.
Dr. Green, I'm just going to ask you, sorry, we've had a few requests if you could slow down. People are finding this information very useful, so if you could just slow down a little bit, that would be great. I'm sorry.
Absolutely, no problem. Get excited. Great. So the second eligibility criteria is that you have to be eligible to receive Canadian health care. So most people assume that means you need to be a Canadian citizen. It's not exactly true. There are other people who are eligible for Canadian health care, landed immigrants, certain status. You don't need to actually have a care card on you to be eligible for Canadian health care. So people who are at the fringes of society, socioeconomically, or for whatever reason, even if they're not plugged into the system, as long as they're eligible for Canadian health care, they're eligible for MAiD. What this is meant to do is to avert the possibility of what is perhaps not politely known as death tourism. The Canadian government is not interested in any way in anybody coming from another country to come to Canada in order to access this care. So Americans cannot come here and pay for it privately, nor can anybody else. So that's really what that's about. The third criteria for eligibility is also relatively simple, and that is that the MAiD request needs to be voluntary. So voluntary means this needs to come from the patient, that everybody else around them is welcome to their opinion, but that they cannot in any way be coercing or encouraging the patient to be requesting this care. So that includes spouses and children, close friends, any beneficiaries, obviously, even healthcare practitioners from a variety of fields. It needs to be from the patient themselves, and part of my job is to ensure that that's the case. I like to hear from all those people. I certainly respect all of their opinions, but ultimately this comes from the patient. And I also need to clarify that there's no sort of subtle form of coercion going on that may be out there. Nothing so obvious as a friend encouraging, but maybe inadvertent financial pressures or other situations that might be encouraging the patient to request a request to die. Those are not valid reasons for MAiD. Those three first criteria, that they're adult, that it's a voluntary request, and that they're eligible for Canadian health care, are usually the simplest criteria to verify. It gets a little bit more complicated after that. Similar to the Carter context, in order to be eligible for MAiD, you need to have a grievous and irremediable condition. But the government has gone ahead and defined what that means and has put in 5 distinct criteria that you must meet, all of them, in order to say that you have a grievous and irremediable condition. This is significantly different than the Carter ruling, and this is very relevant to the chronic pain community and to the mental health community in particular, and I'll get to why in just a moment. So in order to have a grievous and irremediable condition now, you need to have all of the following. you do need to have a serious illness, disease, or disability. So there should be a diagnosis. You also need to be in what's called an advanced state of decline in capability. That is not clearly defined in the law for what that means. And the controversy about this particular eligibility criteria is just about the clarity about whether that needs to be a physical decline or could include a cognitive decline. And most people in the community that provide MAiD will tell you it means either or, but that has yet to be challenged or clarified from the legal community. So I'll just say there's some controversy in what that means. And basically this is being left up to the physicians to decide when it's in an advanced state. That advanced state in decline in capability, and basically what this means is people are not functioning at the level that they normally would. So usually that they require help with their activities of daily living to the point that somebody would say they're in an advanced state of decline. It's probably as clear as I could define it. That advanced state of decline needs to be considered irreversible for this law and for this criteria. And it should be clarified that it is clear in the law that that state of decline in the patient is irreversible by any means acceptable to the patient. So just because there's the possibility of reversibility, if that treatment plan is unacceptable to the patient, that is acceptable by this criteria. I can clarify that if it's too confusing later. Also for this eligibility criteria, the patient needs to be suffering unbearably. And that is a criteria that is determined both between the physician and the patient, but primarily this is a subjective conclusion by the patient themselves. It's very clear in the law that the suffering could be either a physical suffering or a mental / existential suffering. So psychological suffering certainly qualifies under this law, explicitly so. And this is generally, like I said, determined by the patient themselves. So in the conversation with the clinician, they often define what that means to them and why they feel that is so. And then, of course, I would just add here that there is a lot of controversy still about this statement, which has been used in a variety of places. A number of patients have been told that this law is meant to address suffering in dying and not suffering in life or in living. And I think that that is a difficult statement for some of the people who have applied for this care to accept, and it is not yet clear whether it is a true statement or not. So I just wanted to address that. The fifth criteria to have a grievous and irremediable condition is that the natural death of the patient has become reasonably foreseeable, taking into account all of the medical circumstances, so not just the diagnosis themselves, but everything. And this, of course, is a criteria that many people have heard a lot about and have seen debated in the media and in a number of places. Basically, this has not been clarified as to exactly what it means, and obviously there's a wide variety of opinions about what it means. And I think it's interesting to take a moment to think about who should decide what it means, whether it's the patient who should decide, whether it's the clinician who should decide, whether it's the health authority, the legal advisor, the best friend. There's a number of people who want to weigh in on what it means. And I think it's interesting and important to discuss who currently does decide what it means. And also taking into consideration that pretty much every legal expert in the country will tell you that this particular condition is unconstitutional, according to Canadian constitutional law. So this is actually being challenged. And so I will just point out our organization, CAMAP, has actually issued clinical practice guidelines to help clinicians to understand and to interpret what reasonably foreseeable means. Obviously, some people believe that the day they are born, they have a death in the foreseeable future. That's not obviously what the law intends. There's obviously been a change along the way to put them on a trajectory towards death. But trying to determine clinically what that means is the aim of this guideline, and has been very well received and used by providers across the country. If anybody's interested, there's a reference there. The AB case is an important case to be made aware of. It's a case of a woman in Ontario recently who's 79 years old with extensive osteoarthritis. She is hospitalized, bedbound, and in significant pain. And she applied for medical assistance in dying, and her first assessment was deemed to be eligible. The second assessor on this case said that she would have been deemed eligible except for the fact that her death was not in the foreseeable future. And a third opinion weighed in saying that she was eligible, but by then the first provider felt uncomfortable providing care for her because if he was wrong in his interpretation, he faced the possibility of prosecution and imprisonment. So this very courageous woman, AB, went to court to try to determine two things. One, whether she could protect the physician from prosecution, and B, whether the court could grant clarity on what reasonably foreseeable means, in her case in particular, and in general if possible. And this case was ruled upon within the past year, actually within the past 6 months, and the judge was very clear about several things that I think are very important. One is that he determined that the determination of who is reasonably foreseeable is to be done by the clinician and not by the courts, and that this woman actually did qualify under the current law to be eligible. And she had a prognosis of probably 8 to 10 years, possibly longer, because her diagnosis, of course, was not terminal. And that had far-reaching implications. I would note that this decision has not been appealed by the federal government or the provincial government and currently stands. And we'll get more to detail of this later if you wish, but there are two challenges in our country challenging this criteria of reasonable foreseeable, one of them here in British Columbia and one of them in Quebec. And one of the plaintiffs in that case, Robin Moreau, here in British Columbia, after the AB case in Ontario was actually then changed and deemed to be eligible for care, and she's actually proceeded to go on for an assisted death. So obviously there's an evolution in thought in what all this means. I say all this because if this criteria of eligibility is struck down by the courts, which is somewhat expected in the next 3 to 5 years in this country, that will have significant applications for those chronic pain patients and those in mental health, because it tends to be the only criteria that they don't seem to currently meet when making applications. I'll just quickly mention that the only other criteria for eligibility, once you're adult, Canadian, voluntary, and you have a grievous and irremediable condition, the other thing is that you need to be capable of making this request, and that means you have the ability to understand what you're asking for, what your diagnosis is, what your treatment options are, what MAiD is, what happens if you get MAiD, what happens if you don't get MAiD. So there's a real clear understanding of the information and appreciation of your situation and a true articulate request. That capacity needs to be present at the time that the request is signed, and there's also, you need to have the capacity to make this request at the time of the procedure itself. That's a very important safeguard that's in this law, so that people who lose capacity along the way for whatever reason are not able to proceed, and that's meant to protect those who are vulnerable or without capacity to begin with. Of course, the outcome of that means that this law does not allow advance directives at present, and that's something that's being looked at in this country over the next couple of years, but whether that will be changing or not. I would just note also the capacity to make this request can fluctuate. The patient has the capacity to make this request and then perhaps takes an analgesic that makes them very confused or delirious for a couple days and then comes back to baseline. This process can continue. However, if they fall down and hit their head and become unable to communicate or understand what's happening, this process has to stop. So just to clarify, there's no provision for making advance directives then for medical assistance in dying in Canada, and you cannot be a mature minor at this stage. How am I doing for time? Okay, not bad. Let's just talk briefly about just a few cases so we have a more clear example, and then happy to take more questions. So case one, this is actually typically what I see. I'm a quite experienced provider. I've actually done about 160 consultations for medical assistance in dying at this point. I've assisted over 60 people at the end of their life, and probably 60 to 70% of the cases I see are terminal cancer patients, and they look like this. This is Mrs. XX. She was 66 when I met her. She has a history of metastatic head and neck cancer. She had been fighting this disease for about 6 years. She'd had multiple surgeries, several rounds of chemotherapy, and treatments with radiation over the course of those 5 to 6 years, and was now in a very significant decline with no active treatment options left to her. She was receiving excellent palliative care services. She had the good support of her family and her friends, and she made a verbal request for medical assistance in dying to her family doctor, who was quite supportive of this idea, but really very unclear what to do and what to do with the requests. These were in the early days still. They found me, and I went out to see her in her home. I assessed her. I found her eligible for care. I found a second assessor, who in this case was her oncologist, who agreed to be the second assessor. He also saw her in his office and deemed her eligible as well. I went back to tell her that. We had a long discussion about choreographing the event. She was a very organized person who had a very clear idea about what she wanted and where it should be and when it should happen and who should be there. And actually very oddly decided not to be either at home or in hospital, and she found a hotel in town that would be willing to accept her and her family and friends. She chose to check into that hotel about 3 days before her scheduled event. She hosted family and friends over those 3 days to say goodbye to them. She had a large screen TV installed at the hotel's pleasure to be scrolling family photos while she was in the room, and had a beautiful ocean view, and invited about 14, there were actually about 14 people there, and had a very beautiful, very dignified, and very calm death, surrounded by family and friends. And that's typically what this looks like for me. I must say the hotel is not typical. But there are other people who approach me, and here's another one. This is a 91-year-old woman who I saw probably 6 months ago, who had a history of polio at age 25. Not something we see a lot of. She was in an iron lung for many months and had a significant amount of chronic pain since that time. She'd seen a number of physicians over the years. She was able to marry. She bore children. She raised them. She had what she felt was a good life, and coped quite well. But when she was middle-aged, at 56, she was diagnosed with post-polio syndrome, which you may or may not be familiar with. I obviously have not seen so many, but it is a chronic neurologic condition with increasing muscle pains and disabilities. And since that time, she'd been having quite a bit of a medical problem and quite a bit of pain. She was found that she was allergic to most medications that were tried to help her, but she does now use about 4 to 5 tabs of oxycodone per day to help control her pain. And she's noticed a very big decline in her quality of life in the past year or so, and she came to me asking for medical assistance in dying. I should mention this is a woman who lives absolutely independently and manages all her activities of daily living at this point. She's quite isolated, didn't have any family in town, and had less and less social contact as she'd become more and more immobile over the past 6 months. We had a long conversation, and in the end, I found her not eligible for medical assistance in dying because I didn't believe she was in an advanced state of decline. She was actually functioning quite well when I met her, and at the time, I was wondering whether her death was in the foreseeable future. Her age plays a role in that, and there may be others who felt that criteria may have been met simply because of her age. But at the time, I wasn't sure on that, and I didn't think she was in an advanced state of decline. And what I found by talking to her was I wondered actually if she would have benefited from other supports, more social programs that she could access, some nursing care coming into the home to help her with personal care, and with a variety of other things that I think that if they were put in place, she might want to continue. And I left that with her to consider over the next 6 months, and she was free to contact me back if she still had an enduring request, in a couple months. Yeah, I think that I've mentioned those things. I just wanted to reiterate, we always need to ask what it is that the patient's really asking for. The request to die is, like I said earlier, is really an invitation to talk. And when I first started doing this care, people used to tell me that and say, just a request to die is not always a request to die. And it used to make me bristle. But I do understand, having done the work for a year, that that's actually true. And not everybody who says they want to die actually wants to die. So it's very, very important to have an open and honest discussion with people and to really explore what it is that they're complaining of. Again, there's a difference between pain and suffering, and a lot of what we can do is reduce suffering. So I'll just go to case 3, just very briefly. Mr. XY is a gentleman relatively young at age 55, diagnosed with juvenile rheumatoid arthritis at age 25. He has tried every single disease-modifying drug possible over the years. He has not been reactive to them. He has ongoing severe inflammation and deformities, had a number of surgeries. He uses a number of pain medication in combination with themselves and still has less than excellent effect. He's currently living in assisted living, but will soon need extended care and realizes he will be needing to move there in a relatively short period of time, which he finds unbearable for himself. And here's a gentleman who kind of typifies the very difficult situation for people like myself who are approached by chronic pain patients who really have a long-standing desire to change their status and not go on, but don't qualify under the law. And I'm forced to tell him that he simply doesn't qualify because his death is not in the foreseeable future, and the way the law is written, he would not qualify. Again, he's had excellent supports around him, so I'm not sure that there's really anything else to add to his care, but would entail having a very good discussion with him about maybe some things we could do in the meantime. But I find these cases very frustrating. And I'm not going to spend too much time here except to say that this woman, similar to the other woman, this is a 71-year-old woman who also had polio at a young age. She was left with a much more significant weakness and dysfunction, severe scoliosis from her polio, required spinal transplant when she was age 10. She went on to have many successes in her life, despite all of this. A very determined woman who obtained a degree, several degrees, worked successfully, also developed post-polio syndrome at a fairly young age, has very severe restrictive lung disease at this point, is in significant pain, has lost the use of 3 of her 4 limbs, and is suffering tremendously. And she is a woman who you will be hearing more about in the future. She is a woman in Quebec who is seeking medical assistance in dying and challenging the constitutionality of this law. And you will be seeing her name and her story in the papers over the next coming years. I think I'm going to stop there because I've been talking a lot and it's already the time that it is. So Leah, I think I'm going to hand it back to you at this point.
Thank you very much, Dr. Green. Wow, that's so much information. It's really interesting. Thanks for sharing your cases with us too. Is everyone able to see my screen? Just want to make sure. I'll take that as a yes. Okay. I'm just going to add a few more resources from Pain BC in hopes to support both providers and patients in this very challenging conversation. And I'm really glad that Dr. Green mentioned that this is a request. When people request to die, it is an invitation to talk. And Pain BC has many resources that can support you in this conversation with your patients. So I'll have a really quick look at those, and then I'd like to get to some questions. So feel free to enter your questions in the chat as I'm just wrapping up here. I wanted to share some news. Both patient and providers will be pleased to know Pain BC is working very hard behind the scenes to advocate for funding a more robust provincial system of care for people with persistent pain. And this also includes access to adequate pain management, allied health services, pain specialists, more education, and of course self-management resources. So this is what we do, and this is where we're supporting you in this conversation as well. We see an incredible interest and momentum within the Ministry of Health. And at the moment, we're very optimistic about a good outcome with seeing more of these resources come to light. So I just wanted to share that we have many resources at Pain BC that will help you provide support to people living with pain in terms of the connection, the support, and the education that they need to make a difference in their lives. So in case they're having that conversation with you and it's really not particularly about death, but more about, you know, I need more support. If someone does need a connection to a crisis line, a trained peer support person, a psychologist or counselor, or perhaps another support person, Pain BC can provide that referral. So here's a service that we provide. It's called Connect for Health. It's entirely free, and the purpose is to support people in pain struggling with those social determinants of health. Things like income, isolation, housing, employment, food insecurity, childcare, elder care, for example, or education, or any other challenge they might have beyond the doctor's office or beyond the healthcare system. So this is ensuring that people in pain across the province have their needs addressed, that they're being supported. And although the statistics show us that most MAiD requesters are usually highly educated with high socioeconomic status, some of these people do also face challenges beyond the healthcare system and do require support. So this is how it works. It's not a hotline per se, but patients can call in. A live person, a very trained, skillful, and compassionate volunteer will get back to them within 3 business days. You can also refer your own patients. There's a form, a referral form on Pain BC's website, or patients can refer themselves. They can either email or they can fill out the self-referral form. And that's a great way for patients to have access to more supports. There's 2 other tools I'd like to talk to you about. One is the Pain BC Toolbox, and the second is Live Plan B. And I'll go into those in very brief detail. I don't want to take up too much time. But the Pain BC Toolbox might be more appropriate for older adults, especially elderly populations who are not as comfortable with technology. This is a PDF document. It's about 30 pages. It does have active links in it if you want to email it to patients, but it's a nice booklet that you can give them. It acts as a resource so that they can take that away and get started with connecting to some other self-management resources or coping mechanisms in their community. I'm just going to have to breeze through these. My apologies for going quickly. The second resource is Live Plan B, and this is Pain BC's free self-management tool. It's a website. It's for people in pain, and you as a provider can refer your patients to this site. The reason it's called Live Plan B is because Plan A may not be possible. They're living with chronic pain. They may not be eligible for MAiD, but there are supports for them to learn to live well again and to be well again. And so it's sort of a focus on returning to function and being well. That's why the name is Live Plan B. And the site Live Plan B is all about providing support, the skills, knowledge, and confidence that patients need beyond sort of the medical system, but beyond the doctor's office. It will help them with managing their chronic illness. And the site is based on the best science we have on how to do that with patients. Oops, sorry, let me just get rid of that there. So the main messages that I'd like to leave you with today are that patients are not alone. It's very important to acknowledge that they're undergoing a very profound shift in their life. Acknowledge their pain is real, remind them that there are supports, they are not alone, and provide them with the hope and the connections to those services that they might need. One of those tools that we also offer on Live Plan B is talking about the pain spiral. And Pain BC talks about breaking the pain spiral, which is that discussion around how to avoid going through that deep downward spiral of suffering and moving away from seeing pain as a grievous and a remedial condition. We talk a lot about how to break that pain spiral and move from a pain-centered life to a function-centered life, or to living well. And how do you do that? So you can find more of those tools on Live Plan B. I'm going to end there, and I'm sorry to be so quick, but I would like to leave a lot of space for discussion today. Again, most of our tools on Pain BC are really about returning to a function-centered life, returning back to the things that make their life meaningful and things that are important to them, and how to get them doing those things again. And I invite you to take a look at Live Plan B. There's 4 main sections, one of which is all about pain education. As we know, that's a very important aspect of patient self-management. Another area that I'd like to draw your attention to is the real stories, in particular Sherry's story. This is a very short video. Sherry's story would be an excellent way to have a conversation with patients, especially if they're bringing up this particular topic. There's also the discussion forum. Pain BC has an area just for people with pain who would like to share, or even those who are supporting or giving care to someone in pain. They can also share on the discussion forum. It's moderated by Pain BC. It's anonymous. It's a way for them to sort of, connect with others and feel like they're not alone, but also to share their feelings and thoughts around this and maybe ask questions too. So I just wanted to point those out. Here are a few more of those threads on the discussion forum that bring up some of these challenging topics and that people find support from others on the discussion forum. So this is my last slide. I just wanted to say, do try out Live Plan B. It's beneficial for you as a provider because it provides more support, perhaps in concert with some of the other services that you might be referring to your patient. It also provides support for the patient beyond your office. It's a great conversation starter or a conversation tool when you're having those sensitive conversations, and it might help to shift the patient to a more positive direction, especially if they're not eligible for MAiD. And of course, it might help you decrease the stress that these sort of situations may bring up. So do take a look. We'd love to have your feedback, and you can also contact me anytime. We do have something new coming out as well. PNBC will be launching a free self-management coaching service next year, so stay tuned for more information on that. But Live Plan B will be instrumental in providing that educational resource for this service, so take a look. Again, my name's Leah, and I can tell you a little bit more about Live Plan B, so contact me anytime. But at this point, I'm going to ask for Dr. Green to share her screen. We're going to take a few questions, and thank you for your patience as we whipped through a lot of the content today. So I'm just going to ask if Dr. Green's back on here.
Yes, here we are.
Okay, great. I'm going to read out a few questions. We have one question here. What happens to people whose suffering is totally profound, who are no longer able to make the second request? It seems somehow cruel to keep allowing them to suffer.
Yes. So, yeah. So just to clarify some detail first, it's not that there's a second request. There is one request that's made by the patient, and it's in writing, but there have to be two distinct assessments. So you're right. There needs to be two fulsome conversations. They do have to repeat themselves to another person. It is considered a safeguard in the law for obvious reasons. It's not just going to be up to one person to decide if the patient's eligible. And I think that you raise a reasonable point, though. Some people, by the time they make their request or get to a place that they feel they need this help, it's very late in the process. And they're not always able to make it through two full assessments. I think that there are some people in the community who feel that is cruel, and others who just understand that unfortunately that is the way that we need to provide safeguards in our community in Canada. We need to follow a rigorous process. For all the complaints about the bureaucracy and administrative burden of the process, I think in the end we're all happy to have that there so that we can help ensure that this is done in a safe and secure way. Ultimately, the answer is if they can't get through two assessments, this process can't go forward. It's just that simple. And until the law is changed, or unless it's changed, that will be the case.
Okay, thank you very much. I see we have a few more questions come in. I hope you don't mind if I just read them out.
Please do.
Okay, the next one is chronic pain can make death more imminent when you factor the implications of a decreased mobility, etc. I think this person's asking you to speak a little bit to that.
Yes, so absolutely, there's a lot of room for discussion. Chronic pain can obviously interfere in people's lives in a tremendous amount of ways, and sometimes it can be obvious that it will be detrimental to the length of their life. I mean, it can involve mobility, it can involve abilities to care for themselves. There's a whole host of factors. I think all those things need to be taken into consideration when assessments are done, and it's part of the complexity of what I do and what my colleagues do is to try to understand the full medical condition and the full implications of the patient's situation as we try to do this. It's not black and white. I absolutely agree with you, and I think that as this care becomes more, I hate to say normalized, but as we become more experienced as assessors and providers, we'll have a much better understanding of what we can and what we cannot take into account while we do our assessments. We're still very careful. Most assessors and providers are quite conservative in their assessments at this point, as we learn to to take all these things into account. But you're right. These are every one of these details needs to be taken into account. Every situation is unique. Every situation is different. One diagnosis is not the same as the other in two different people. That's for sure.
Mm-hmm. Well, thanks very much for that. This is another question we've got here. I'll just read it out. What is listed as the cause of death where assisted suicide or voluntary euthanasia has been undertaken? So do provinces differ?
So great question. So it does differ province to province. Health is actually implemented provincially and regulated provincially in this country. So each province can do what they wish, and there has been some diversity across country. I'll tell you that in British Columbia, right now, when I fill out a medical certification of death on a patient that I've assisted, the #1 underlying condition that causes death is written in specifically as medical assistance in dying. That's what I write. The #2 underneath it, I will put in the